Parvovirus B19 is exceptionally small. At just 5,000 nucleotides, it is one of the simplest pathogens known to infect humans. Yet this tiny particle can cause a harmless transient rash in a young child and trigger fatal bone marrow failure in an adult. To understand this discrepancy, we have to look at its biological constraints. B19V is an erythroparvovirus, a non-enveloped, single-stranded DNA virus. This animated diagram illustrates how B19V enters a host cell. Its clinical pathology is driven by strict tropism. The VP1U and VP2 regions of the capsid physically interlock with the blood group P antigen, a globoside receptor found exclusively on human erythroid progenitors in the bone marrow. If an individual naturally lacks this P antigen, the VP2 capsid has nothing to bind to. These individuals possess absolute natural resistance to B19V infection. The virus has no mechanism to efficiently infect other primary target cells. Its clinical footprint is governed entirely by this tropism. It is a specialized, highly targeted destroyer of the red blood cell assembly line. Because it specifically attacks red blood cell production, B19V infections follow a strict two-part timeline. This chart maps the biphasic pathogenesis model. The x-axis tracks the weeks post-infection, while the two y-axes measure viral load and antibody levels. Phase 1 is the acute cytotoxic phase. Massive viremia, reaching up to 10 to the 14th particles per milliliter, causes direct destruction of those erythroid progenitors. This forces an immediate, sharp drop in new reticulocyte production. Moving into weeks 2 and 3, the viral load drops toward zero. Simultaneously, the blue line surges upward. The body is mounting its Phase 2 antibody response, producing IgM and IgG to clear the virus. Notice where the physical symptoms finally appear, anchored to the peak of the antibody curve. The classic rash and arthralgia are triggered by immune complex deposition. They are an immune response, not a direct result of active viral replication. Diagnosing and treating a B19V patient requires knowing exactly where their immune system places them on this biphasic timeline. To map how different physiologies react across this timeline, we use a comparative host matrix. We will track the syndrome, mechanism, and treatment across 5 distinct host profiles. The most common host is the immunocompetent child. They present with erythema infectiosum, often called fifth disease, which begins with a sudden facial erythema that spreads to the trunk in a lacy, reticular pattern. Returning to the timeline rule, this rash is a Phase 2 immune response. By the time this visual symptom appears, the initial viremia is over. The child is no longer infectious. The disease is self-limiting, and diagnosis relies on clinical presentation or detecting IgM. The presentation shifts completely in a normal adult host. The facial erythema is usually absent. Instead, adults, predominantly women, develop polyarthropathy syndrome. This manifests as symmetrical arthralgia in the small joints of the hands, wrists, and ankles, mirroring the presentation of rheumatoid arthritis. Like the pediatric rash, this adult joint pain is a Phase 2 immune-mediated problem. Because the symptoms are caused by antibodies rather than active viremia, providing intravenous immunoglobulin, IVIG, is ineffective. In a competent immune system, the virus is swiftly neutralized. The clinical disease observed is an echo of the body's own defense. The clinical math changes drastically for patients with underlying hemolytic conditions, like sickle cell disease, thalassemia, or hereditary spherocytosis. These patients have an immense baseline need for continuous red blood cell turnover. When Phase 1 cytotoxicity halts new progenitor cells, they experience a catastrophic drop in hemoglobin, known as transient aplastic crisis, or TAC. The diagnostic criteria for TAC requires severe reticulocytopenia combined with acute worsening anemia. Standard protocol involves detecting B19V IgM and confirming viral DNA by day 3 of the crisis. For patients with sickle cell disease, the clinical presentation is definitive. The acute reticulocyte drop is diagnostic on its own, making an invasive bone marrow biopsy unnecessary. The required intervention is immediate. These patients need repeated blood transfusions to maintain oxygen delivery until their immune system can mount a Phase 2 clearance. When the bone marrow is already operating at maximum capacity, a temporary halt in production becomes a life-threatening emergency long before antibodies can form. In row 4, we move to patients with leukemia, AIDS, or those receiving organ transplants, hosts who lack the capacity to mount an effective antibody response. Here, the biphasic rule breaks down. Because these patients lack the cellular machinery to mount a phase 2 response, they cannot clear the virus. The phase 1 viremia persists indefinitely. This persistent cellular destruction results in pure red cell aplasia, and because the patient cannot mount an immune response, there are no immune complexes forming in the skin or joints. They present with profound anemia, but no rash and no arthralgia. Standard serology testing for antibodies will yield a false negative. To reach a diagnosis, clinicians must use high-titer quantitative PCR to detect the massive viral load directly in the serum. When a bone marrow biopsy is performed, pathologists look for this exact histological hallmark, an abnormally large, deeply stained giant pro-normalblast, standing out starkly against a background devoid of other erythroid precursors. To treat pure red cell aplasia, clinicians administer high-dose IVIG. This artificially supplies the phase 2 clearance mechanism, providing the antibodies the patient cannot generate themselves. Without an immune response, the virus silently destroys the blood supply without ever triggering the visual warning signs of infection. The final host profile in our matrix is a seronegative pregnant female exposed to the virus. If transplacental transmission occurs, particularly before week 20 of gestation, the virus targets the developing fetal erythropoiesis. This leads to severe fetal anemia and non-immune hydrops fetalis. While the virus destroys fetal red blood cells, Parvovirus B19 is non-teratogenic. It does not cause congenital malformations. The mother herself often shows no signs of infection. Because maternal symptoms are an unreliable indicator, all seronegative mothers exposed to B19V require rigorous testing and monitoring. To differentiate between past immunity and a recent dangerous acute infection, clinicians use an IgG avidity assay. Low avidity confirms a recent exposure. In pregnancy, the clinical severity is dictated by the developmental timeline of the fetus, completely divorced from maternal symptoms. Beyond acute presentations, modern molecular diagnostics have revealed a secondary complexity regarding how parvovirus interacts with human tissue. B19V can enter non-permissive cells, like those in the synovia or heart, through a process called antibody-dependent enhancement. Once inside, the viral DNA remains dormant for decades in healthy asymptomatic individuals. This creates a diagnostic challenge, mapped in this flowchart. On the right, running a qualitative PCR on a tissue biopsy is invalid for acute diagnosis. It detects dormant DNA from an infection years ago, generating false positives. The rule for B19V diagnostics is strict. Molecular detection must rely on quantitative serum PCR, explicitly correlated with active clinical symptoms. Finding viral DNA in a solid organ is not proof of active disease. In virology, presence without physiological context is merely noise. While B19 is the most established human parvovirus, the Parvovirus family contains other emerging pathogens. Human Bocovirus 1, or HBOV1, is a frequent driver of pediatric respiratory tract infections. It shares a similar diagnostic challenge with B19V. HBOV1 DNA persists for months in airway secretions. Confirming an acute infection requires detecting a high viral load, exceeding 10,000 copies per milliliter, alongside active seroconversion. Another relative, cuttavirus, has a tentative association with cutaneous T-cell lymphoma. Then there is the adeno-associated virus, or AAV. Because it is apathogenic and remains latent without a helper virus, it has been engineered into a successful vector for modern gene therapy. However, anomalies arise. In 2022, an unexpected correlation emerged associating AAV2 with acute childhood hepatitis, though its causative role remains unconfirmed. The Parvovirus family illustrates how a pathogen's impact is defined not by its own genetic complexity, but by the specific physiological vulnerabilities of the host it invades.